Hi, everyone. Good afternoon, and a very warm welcome to all of you to the inaugural session of the Journey to Resilience, a GLC for HSR learning series. There is some amount of technical challenge that Dr. Krishna Reddy is currently facing, but he will eventually join. But in the interest of time, we will get started. Just making sure that I'm audible.
Yes, please.
Yes, thank you. So the Global Learning Collaborator for Health Systems Resilience, in its fifth year now, is a cross-regional platform that brings together policymakers, practitioners, researchers, and health systems leaders to exchange learning and advance practical approaches to building more resilient, people-centered health systems. We are pleased to introduce to you today this monthly learning webinar series as a space for focused discussions on priority health systems themes, drawing on evidence, regional experiences, implementation lessons, and expert perspectives from across contexts. Today's inaugural session focuses on a foundational requirement of building resilient health systems, that is, strengthening health governance through robust assessment and monitoring systems. Today's session will focus on lessons from national and subnational health systems, international experiences, and the role of digital technologies in enabling smarter, more responsive health systems across. It is now my pleasure to quickly introduce our speakers for today's session. So, Dharma, if you can just bring up the slide. Okay, it's already up. Today's session will be moderated by Dr. N. Krishna Reddy, CEO of Access Health International, a renowned practicing cardiologist and health systems expert. Dr. Reddy has over 35 years of experience in healthcare with a strong focus on improving access, quality, and outcomes. Dr. Reddy has held leadership roles across health systems, strengthening healthcare delivery, medical devices, and clinical practice. We will begin the individual presentations first, and before that, I will also introduce the other speakers. So we will start with the presentation from Maulik Chokshi, Global Director, Health Systems Research and Policy at Access Health International. Maulik is a seasoned health systems professional with over 24 years of experience in research, training, and policy design. His work spans healthcare financing, pharmaceutical procurement and pricing, immunization, maternal and child health, and health system strengthening across regions. Today, he will be speaking on national assessment, monitoring, and surveillance, the India experience. Our next speaker will be Arun Nair, State Director, Kerala from Access Health International. Arun is a health systems and financing expert who focuses on public financial management, national health accounts, health financing programs, and health systems research. He also serves as a technical expert on several committees with the government of Kerala. Today, he will be speaking on operationalizing assessment and monitoring at state and district levels, lessons from Kerala. We will then hear from Dr. Rohini Omkar Prasad, Regional Director, Southeast Asia, Access Health International. Dr. Rohini is a public health physician and policy specialist with over 15 years of experience in health system strengthening, digital health, and evidence to policy translation across the Asia-Pacific region. She has led multi-country research and advisory work across chronic disease, climate health resilience, sustainable financing, and digital transformation. Today, she will share insights on strengthening health governance through assessment and monitoring, insights from Singapore. Our final speaker will be Supriya Kotra Prabhakar, Technical Head, Digital Health Technology Applications and Services at Access Health International. Supriya is a digital health informatics professional with 20 years of experience in building technology solutions for healthcare. Her work spans digital health initiatives, multi-stakeholder partnerships, advisory support to startups, and capacity building efforts across several countries and with international organizations such as the WHO. Today, she will be speaking on digital technologies for smarter assessment, monitoring, and surveillance systems. So we're grateful to all our speakers and to all of you today for joining us, and we look forward to a rich and practical discussion. We will start with individual presentations. I'm not sure if Dr. Reddy
Stuti, I'm available.
Okay, great. Perfect. So welcome, Dr. Reddy, and I hand it over to you. And just before that, followed by the individual presentations, we will have a panel discussion and we'll be able to open a round of audience Q&A. You can keep sending questions in chat while the session is in progress, and we will take it up towards the end. With that, I invite Dr. Reddy to kindly take over and set the context. Thank you.
Yeah, thanks, Stuti, and thanks my host speakers as well as all the online participants of the GLC. Continuing with the promise, I think that was made in the annual conclave, that the journey of learning will continue. So we are beginning with the monthly sessions. I think every fourth Thursday on the same timing. The timing is chosen such that all the regions in Asia and Africa are able to attend, and also if people are alert in Americas, they may be able to attend. But some sessions we will be convening in the evenings for the American population. So there will be a series of these learning sessions on the core function of the governing. I think the governing function was brought out as one of the critical factors in how countries responded to the COVID pandemic. While everybody talks about governing, there is still ambiguity as to what exactly we mean by break it down into some of the core activities of the governance. To bring more clarity, I mean, today's session has more of from the researcher's perspective and the subject matter experts' perspectives. But this will be followed up in the next month from a practitioner's perspective. Any governance, that means any decision making, whether it is at a policy level, at a strategy level, at a planning level, or implementation level, commences with the assessment of current situation. And when you say assessment of current situation, the assessment of the health status of the people, what are its determinants, both the medical as well as the non-medical determinants, and what are the health needs arising out of the disease burden, which defines the health status. When we say health needs, we normally, I mean, as a part of the GLC language, we always say all health needs of all people at all times. So how health systems actually respond to these health needs of all people, of all needs, and of all types of health needs, from health promotion to palliation. While needs are defined, but how people actually seek health care, there is a disconnect between health needs and health-seeking behavior, because many times patients seek health care when they have illness. The concept of health promotion, the concept of disease prevention, the concept of early detection, generally the people's health-seeking behavior does not reflect that one. So that means there is a gap between the health needs and the health-seeking behavior. And the health-seeking behavior, actually, that is how the health system responds to the health-seeking behavior, not to the health needs. If they want doctors, if they want diagnostics, if they want procedures, if they want hospitals, both private sector and public sector, try to respond to this health-seeking behavior, while the ideal health system has to actually respond to the health needs of the people to improve the health status. And as I think everybody is aware, that health status is increasingly, at least 2/3 of health status is attributable to the non-health determinants, the social, economic, environmental, commercial, cultural determinants, which brings to the case how the governance systems are actually assessing the health status in all its dimensions, including its upstream determinants and the downstream health systems response. Each country at a national level or a subnational level whether it is state or province or district or even going down to the block level, have their own systems of assessment, their own systems of monitoring, their own systems of surveillance to inform policies in the decision-making systems. While each country has its own systems and they are at different levels of maturity, this today's session is mainly meant to understand through case examples, whether it is in India or whether it is in Southeast Asia or at a state level, what actually is happening in terms of the fundamentals of governance system, of how the governance actors are actually assessing the health systems, assessing the health status, monitoring the performance of the health systems, monitoring the programs, monitoring the policy implementation, and have surveillance systems to be prepared for any public health emergency in terms of alert mechanisms and the response mechanisms. So that's why, I mean, in my perspective, these three elements of governance are most fundamental for any governance system to be function in a more efficient and effective way. So given this background, I think today we will have a series of 4 panel speakers, starting with Maulik, who will be covering the national context with a India case example. Then we have Arun, most progressive state, that is Kerala. I think he can outline how the Kerala's governance system looks into these assessment methods, monitoring methods, and the surveillance methods with a more practical examples. And Rohini will actually cover the Singapore system as well as some of the examples from the Southeast Asia. But connecting all these things, I think what is more important is the information system is cross-cutting function to enable these 3 things. In the absence of information systems, these 3 things are not possible in a more efficient and, I mean, they were there before information technology systems. Monitoring was happening, surveillance was happening, assessments were happening, but in a different methodology. Whereas information technology has dramatically improved the efficiency and the effectiveness of this system. And with the digital transformation of health systems across the countries, Supriya will take us through some of the case examples in terms of how we actually leverage the digital technology to make these core governing function of assessment, monitoring, and surveillance most efficient and effective. But more importantly, I think what is going to be discussed also is, even if the countries have these systems, I mean, we have a lot of national health surveys, there are surveillance systems, there are monitoring systems program-wise, whether there is capacity in the governance systems to use this information in informed policy making, informed planning, and informed action. I think what many countries lack is in this capacity, whether it is a DMHO at a district level or a health secretary at a state level or ministry at a central level, the capacity to use this information in translating information into evidence-informed or evidence-guided policy making, policy implementation, program implementation, and monitoring of health systems performance. So with this, I think the background as a context setting for this today's learning session, and also there will be back-to-back follow-up learning session next month. I invite Maulik to start his presentation summarizing at the national level what it should be and what's happening. Then we will have a series of presentations, and then we will have an open interactive discussion with the participants. I think our team, communication team, will be gathering those questions posted by the audience to the speakers in particular, or if somebody also wants to make comment, adding to the discussion point, because this is a collaborative learning. So we want it to be as interactive as possible. With these few words, Maulik, over to you to present your perspectives on the national level systems.
Thank you, Dr. Reddy, and it is being pleasure here. I am relaying my slides. Can you see them?
Yeah, they're just coming up. Yeah.
Right. So thank you, Dr. Reddy. And as you relayed, I think so it is a very important aspect for any health system to have intelligence because health systems evolve, disease profile evolve, the capacity needs and outcomes evolve. So it is very important for a national, state, sub-district level to have stochastic information, real-time information to make informed decision. And what I'm going to present is just a kind of I would say a tip of an iceberg because it's a very complex thing that we are talking about. And the complexity starts with what I'm presenting right now. That when we talk about health system, right, and information, what we are talking, and I'm taking WHO building block as one of the framework. We are talking about how do we assess delivery of healthcare? How do we assess not only distribution but performance of workforce? How do we assess the information coming in, the quality of information and the real-time information? How do we assess whether commodities, whether it's diagnostic or medicine available both at state level, district level, and at a sub-center level? And how do money kind of, because money becomes a very important lever for functioning of everything, right? How do we assess whether the money is enough, and money availability is enough? Do we need more money? In which area do we need more money? And you rightly alluded again that these are all kind of 5 different pillars, and the information will be flowing from 5 different pillars. There needs to be a structure where these different pillars kind of interact with each other to provide an evidence where policymakers can act on. But having said that, whether we talk about today or 2000, it was when people started talking a lot. I think that the first talking about system strengthening was in 1993 World Bank paper on investing health. But in 2000, again, WHO came out with a paper on health system strengthening. And from there onwards, this whole intelligence or data or assessment has started taking a forefront in decision making. And when I say this has become a forefront in decision making, what does it mean? So I'm taking India as an example, as you said. So I am an individual, and the system's outcome is to ensure my health. The system's outcome is to ensure responsiveness, that if there is change in epidemiological profile, if there is elderly population coming in, there is a new infection coming in, we are responding to that. And ensuring that people don't have to spend out of pocket while accessing healthcare services. So money does not drive health outcomes. So if I keep these as my outcome goals, and if I look at what affects this, because that will determine what I need to measure, then this is just an overview. That if I start talking about access to care, we talked about human resources for health. Now, human resources for health is a function of Ministry of Health and Family, Ministry of Human Resource Development. If we start talking about service delivery, capacity of human workforce, the Ministry of Health and Family Welfare comes in. If we start talking about commodities and diagnostics, their quality, then Ministry of Department of Pharmaceutical comes in. If we start talking what you talked about, Supriya stock, I think the Ministry of Electronics and Information comes in. These all ministries come together and they have got their own assessment, kind of not framework, but touch points to see that how they are evolving or how they are functioning. But it is also important to measure that, like Ministry of Human Resources Development, Department of Pharmaceuticals, Electronic and Information Technology, don't work in Indian ecosystem. Now, globalization has also broken boundaries. And what I mean to say is that if, let's say, again, I'll take Department of Pharmaceutical example. If you want to ensure availability of commodity, a particular medicine in your country, it's not only dependent on the production level or APIs, but it also depends upon the API imported from our partner countries. Now, any difference in availability of API will affect the commodity security in that particular segment. So this globalization has broken boundaries, and hence what it is important at a national level to even assess that how we are becoming secured in various departments, whether it's health financing, whether it's commodities. How is national government of India is ensuring that how nation as a whole is becoming secure to this kind of global shocks. Now, these are directly affecting health of an individual, health outcome, right? But there are also social determinants of health which affects health of an individual. And how do we measure whether there is a clean drinking water, or whether you got good kind of housing condition? And now with climate change, that housing conditions are climate resilience. What are the price, consumer price? What is the consumer currently paying for different commodities? Women and Child Development focusing on maternal and child health issues. Ministry of Social Justice Empowerment focusing on elderly care. Panchayat Raj Institute focusing on block level accountability and ensuring that delivery of services. Ministry of Environment again making sure that with climate change, heat resilience, how those kind of heat waves are coming in, what are indicators we are measuring to make sure that people's health is taken care of, and that's responsiveness that we are talking about. And Ministry of Rural Development with Mandrega making sure there is a purchasing power. So these all determinants of health are also being measured at a regular level so that input goes as an health outcome of an individual. As I said earlier, financing becomes a very important role. And again, if I want to see that how much money a state is investing in healthcare, I have documents from Ministry of Finance, from Reserve Bank of India, and budget documents of government, which can help me in tracking that what kind of money is available. And if I want to invest, what kind of money is needed? Because if I start talking about fiscal space is getting constrained as far as healthcare is concerned. And with fiscal deficit increasing at a state level and a national level, obviously it's going to constrain social sector investment. In that case, how do I see what is the fiscal space available? Then you have a tracking documents which our Reserve Bank of India does consistently over a period to see the fiscal space availability and what of center-state relationship happening as far as financing is concerned. And so is the role of development partners investing in a particular specific program and tax structures created in the Ministry of Finance. Because I'll give you an example. A couple of years back, inhaler were very expensive. Ministry of Finance then played a very important role in decreasing tax on Ministry of Finance, tax on that inhaler, so that the prices of inhaler came down. So in nutshell, when we start talking about tracking of or creating a framework or a system assessment framework which affects health, responsiveness, and financial fairness, it's not only healthcare delivery or Ministry of Health and Family Welfare's role alone that can ensure assessment, but various ministries and various departments need to come together to ensure that we are tracking not only the outcomes or immediate input in terms of human resources for health or medicines or infrastructure, but medicines, infrastructure, and human resources are also working in a kind of larger ecosystem. Consumer behavior also is an outcome of larger ecosystem. So we are able to measure this kind of evolution as well. Globally, I think so. India, as I said, globalization, India is part of a lot of treaties, both in terms of leadership, information, financing, workforce. And we have been kind of various systems framework are existing, whether it's WHO Global Observatory Framework or Global Burden of Disease Framework or Health Account Framework for financing or National Health Workforce Account for workforce or International Standard Classification of Occupation, which can help in assessing what is India doing and what is India playing role both domestically as well as globally. Now, this becomes very important again when we talk about human resources for health. India is also a major kind of exporter of human resources of nurses and doctors. Now, if we start talking about a global assessment that there are shortage of doctor in India, but India is still able to export doctor, or India keeps on continuously exporting doctor, then what needs to be the production capacity so that we are able to meet our demand? So international standard classification of occupation and this kind of database helps in assessing what is the production capacity, what is the percentage of export, and henceforth, if we need to meet domestic demand, what kind of production we need to do, and if we want to do the production, what kind of investment will be required, which again Ministry of Finance comes into picture. So these are how kind of various indicators are coming together in assessing what role India plays as far as global community is concerned. At national level, we need to measure how healthy is our population, what is making our population healthy or unhealthy, from what they are accessing healthcare, how is assistance performing, what are disease surveillance kind of platform, and we have instruments in form of national family health surveys, annual health surveys, social development goal dashboard, national sample surveys, RBI data set, HMS data set. So information does exist at different level, and aligned to it, I think so WHO Health Matrix Network is also kind of strengthening this evolution of intelligence function. But are we doing enough? If you say that health status assessment, I think so it's done every periodically, 3 to 5 years. So again, I kept on using the word stochastic. So we need to create this stochastic measurement mechanism. Disease burden is an annual survey, but can I access district level disease burden data? We need to be mindful about it. The NSS sample data, again, is kind of a sample based. We need to see that how that sample could be extrapolated at a national level. So each and every kind of function, there are data sets, but I think so they are either moderate or they are weak as far as integration with other data sets is concerned. And so we need to evolve from there. The biggest blind spot we have is private sector. We don't have private sector data. Periodicity of the data, I keep on alluring, is a problem. The quality of data and the completeness of data is a challenge. And obviously, who owns the data, whether it's federal government or a state government, and how the data exchange happens between federal and state government is something that we need to work on. In private sector, we have some information through Information Insurance Bureau in terms of spread of our facilities. We have got some network information. We have some consumption data. So data does exist to see what's happening into our ecosystem. But we need to ensure that these data sets are able to talk to each other to make real world evidence or real world decision. And towards that, I think so what has happened recently is the last 2 minutes I'll take or a minute I'll take. We had kind of evolved IPHS standards in 2022. We created a kind of a digital platform which allowed to measure IPHS, current IPHS status of around 2 lakh facilities, 10,000 facilities, including PHS, CS, and sub-district. Based on the scores across kind of IPHS norms and their current status, now decisions are made in terms of what is the deficit happening at a facility level, what are the needs at a facility level, and henceforth, when the state defines or a district defines or a facility defines its program implementation plan or NHM, I think so there is a potential or a possibility of then kind of creating the structure aligned to the needs of community and deliver it. But again, quote unquote, this is again a public sector which caters to 35% of population, more than 65% of population. And I think so that is something that we need to kind of strengthen as far as data sets are concerned. So I think so I'm close to my 10 minutes and I'll stop here.
Yeah, thanks, Maulik. I think in the brief 10 minutes, you given the framework needed for assessment, and also the large body of information that exists at a national level, right from global sources as well as national sources. But you also pointed out what needs to be done to make this information applied in decision making. I think that's where some of the gaps that are identified. There may be plans to fill in those gaps so that. I think any questions we'll take up later. I think Stuti is summarizing all those questions. We now go to Arun, who covers at a state level, because state is the actual implementation agency and the health is a state subject in India. Arun, over to you to give your perspectives as a health systems person as to what's happening at a state level and how it is connected with national and global levels.
Thank you, sir, and Maulik, for setting the stage. Am I audible? Yeah.
Yeah, yeah.
So you may please show the slides. Yeah, I'll take a very brief presentation, and it is from the point of view of governance and how actual implementation happens, and what are the systems in place from a state perspective. So Maulik has very well have articulated about what are the ways in which data is being generated at each levels, and what are the key problems, exactly like what he mentioned about how data sits in silos, and what happens from a planning perspective. My slide, my presentation is basically on looking at how state, from a state perspective, how the population health management happens at the state level. Please put in slide mode and go to the next slide. Yeah. So to start with, at the state level, especially from the state where I come from, Kerala, the department, the service delivery or the public health action is not basic only the responsibility of health department. It is already long back a multi-sectoral function, and please go to the next slide. Basically a multi-sectoral function where a lot of role is being given to the local self-governments. So the entire health system is driven from a governance point of view, which also includes data driven decision making, not by alone by the health department. So it's from 1996, the state of Kerala has already transferred the administrative, financial, and planning management functions of the health facilities to local self-governments, both urban and rural local self-government. So it is not only delivered locally, but deliberated, discussed, funded, supervised, and supported by at the local level with a large involvement of communities. So local governments, why local governments? Because they know at the ward level much better information about households, settlements, vulnerable families, people with extreme poverty, people with risks, and the institutions are under their domain, so that they have the leverage to act upon things which at the local level. Although all the programs happen, central or state programs happen through the service departments. So what it brings is that there is a lot of interaction between and various data points between the service delivery point as well as the governance function, that is which happens locally at the by the ward members or the local self-government presidents or the urban local body presidents and members. Now, another thing is that beyond health department. So, for example, if we talk about from a point of view of on health, which is being talked about everywhere, on health or AMR surveillance or zoonotic diseases and all. It's not only the health department who has, because local governments have much more power to convene other departments, which include sanitation, water, education, and all other line departments. Hence, it becomes a more resilient. The response system is more resilient and near to the community. So this data management, data flow of various departments all get convened with health, with the support of the local governance system. So the good advantages with the system is to identify issues, convergence of departments, and a lot of people's engagement in resolving these issues. Please come to the next slide. Now, so the next slide, please. Yeah. So now, how do we understand the population health needs? Of course, the system, health system has its own way of understanding it. Understanding system and data systems in place, which Maulik had also briefed. IDSPs there, HMIS systems are there. But otherwise also there's a lot of data collection around people at each local body, people, vulnerable population especially. So you may remember in January, Kerala was the first state to declare extreme poverty free state. So a lot of extreme poverty. So the definition of extreme poverty is not only income, but it is also linked to health needs, health, deprivation, and people with palliative or bedbound, homebound patients. So identification of people or identification of beneficiaries is something which also happens at the local level. It is through the home visits or the routine visits by the staff, but being supervised and being monitored by the elected representatives. Kudumbasri is the biggest self-help group in the country, which is from Kerala. So they are also part of the one. There is Janakiya Arogya Kendrams and volunteers who are from the community who are also part of this process. So from there also a lot of information and data gets collected to the health system level. And in each local self-government, there is something called Health Standing Committee, which is one member being given the responsibility for the entire administration, public health activities, grievance redressal, as well as various other requirements with regard to the health system and community engagement as part of the local self-government, who interacts with the overall health system which is in place. Next slide, please. So how this actually works in that, so the next slide. Yeah. So if you take a normal period without any emergencies, so if you take the example of NCD, so there is a lot of emphasis now on screening. The screening is something which is being done very vigorously by the health system, supported by the local self-governments, to find out who are people at risk from NCDs. And there is a system in place and an entire data system in place, which is through an app called Shaili. Shaili means your behavior, to understand what are your lifestyle issues, what are your lifestyle risk factors which contribute to your NCDs. This entire data is being collected through the health system, normal system delivery workforce, but supervised by the LSGs. And then this helps in ensuring regular follow-up of medicines, counseling, and follow-up at the PHCs or the family health centers, which is the first level primary care unit. And if required, they are referred, and then this referral, most of the state is also having care coordination now in place, when the referral is completely through an e-health based system, where you can track the patient, where the patient has gone, and at what facility the care was provided. Now, there is entirely a complete digitized system which works for palliative care, identifying all bed-bound, home-bound, and bed-bound persons, and with the support of community and NGOs. So it's a huge network being roped in by the LSGD department. It is done by the LSGD department with the support of health department, but that entirely data-driven thing, where the data is shared between both departments as to find out the put in place a process for the palliative care system. Now, this entire system, LSDs have a large role, because this data which they collect at that level, they're being used for lifestyle support campaigns, lifestyle modification, and they use their plan. They can use their plan fund for, setting up open gyms, yoga centers, and also plan deliver projects for lifestyle modification, and within their plan fund, within the local fund network, and also help the panchayat members are supporting the department to trace people who drop out of the after screening, drop out of the follow-up chain. This is something which is done. This is an example of how it is done through a normal period. Next slide, please. Now, as you all are aware, again, a Nipah case is there, and this is COVID and pandemic management. The COVID situation, which was managed quite well in Kerala, has helped in a lot of, putting in place a lot of effort and stress and effort on the emergency and pandemic management. So this entire, so if recently 3 weeks back, a Nipah case was reported in Calicut. There is a system which is put in place already, a full-fledged governance system with 16 to 17 committees for with the support of local self-government for identifying patients, isolation, infection control, tracking of patients, contact tracing, and all systems. And in this this larger system of pandemic management, emergency management, there is not only the health and local self-governments, all other line departments are also part of it. And there is constant data exchange, required data exchange at the state, district, and the levels beyond, which is below, that is block and to the facility level. A lot of this, once a system puts in place, a lot of the information, education, communication activities and home visits and everything, it is supported by the local self-governments with the health department through the seamless flow of information. Please. And I'll stop with the next slide, which is what the state is now preparing, which is the development of the plans for One Health, which is a very comprehensive set of activity using extensive data from all departments which is currently happening. So the One Health program, which started as a pilot program, is now expanded across the state, all districts of the state, and this is with the support of local self-governments, where district level and facility level on health plan, pandemic preparedness plan is being done. Now, every panchayat, almost all local self-governments in Kerala now, by I think June end, is going to have a pandemic preparedness plan, where all data, which includes one of the key points that Maulik mentioned, is about this black box of private sector data. In every panchayat, what is the availability of even private sector infrastructure with regard to pandemic preparedness, or which is like, for example, a laboratory surveillance network, private hospital network, bed, so it can help in bed management, availability of beds and specialists. Yeah, and along with that, an environmental zoonotic disease, surveillance plan, and a larger epidemiological surveillance for the last 5 years is put in place, so that every district, this is collated at block and the district level, with every district having a district pandemic preparedness plan. That's where the current level of use of data is happening. Now, all this requires seamless integration of the existing data points, and which is a system which is put in place currently. This is also not a full-fledged system, but to great extent this is being put in place, and that is because of the governance framework that we have, which is other than health, with the role of local self-governments. I'll stop here. I think the next slide didn't come, but okay, fine.
Yeah, thanks, Arun. I think you brought out a different perspective of governance. I mean, one, of course, is the decentralization. I think there is a significant decentralization to the local government systems, which are made accountable and responsible for assessing themselves the local situation, monitoring what's happening, and making the local healthcare systems accountable for the response that they are giving. This is, I think, one of the important point of what Arun has brought out. It is not only the data-driven decision making, but it is also a decentralized, a live a kind of a dashboard through live observation. I think this is an interesting model of how the assessment, monitoring, and surveillance systems, I think, optimally should be done, not just depending on only a centralized database, but actually decentralizing to the local governance level and empowering them to act based on the local information. I think that's one of the key message I think I could infer from the presentation. But I think, Arun, you will be ready for some more questions related to this interesting case example from Kerala state level. All of us are aware that not all states are at this advanced stage of governance systems as Kerala has. And thanks for sharing a real world approach. In the hospital systems, we use the word walk around. That means somebody walking around and subjectively assessing in addition to the objective data that is measured. We go to the next topic from Rohini on the perspectives of an advanced system like Singapore, a high-income country and highly developed advanced health system, Singapore. What actually it is doing, and or in the region also, Still, despite advancement, what are the gaps in the current way of assessment, monitoring, and surveillance systems? Rohin, over to you.
Thank you, Dr. Reddy. I'm just trying to bring up my slide. Does that work?
Yeah.
Okay, so I don't have many slides. I think just a couple which sort of anchor what I'm going to talk about today. I'm going to talk about Singapore, and if you consider in terms of scale, Maulik talked about India, Arun talked about Kerala. Singapore is much smaller. It is a city-state only with about 6 million population. However, it has had a very, what should I say, very dedicated 6 decades of transformation, not just financially and as we see, but also in terms of health. It has had effort put across all these over years. And this snapshot that you see over here tells you a story of how the country has improved from what it was when it achieved independence in 1965 to what it is now. So life expectancy increased from 65 to 83.9 today, which is among the highest in the world. The healthy life expectancy is 73, which is the highest in the world. But what this picture tells you also is that there's a 10-year gap between healthy life expectancy and life expectancy, which means literally that there are people living for 10 years unfit, unhealthy, with chronic health challenges as well. So infant mortality, of course, has fallen to 1.4 per thousand live births. Out-of-pocket spending has dropped from 48% to about 25%. And given that Singapore spends about 5% of its GDP on healthcare only, this is a significant ratio to look at as well. So Singapore ranks also 8th globally in the Universal Health Coverage Index. But against these good indicators, the other picture is, of course, that hypertension, chronic disease prevalence has doubled since 2010 and affects about 37% of adults. And the population is aging rapidly. And a very common statistic you'll hear when you're in Singapore is that 1 in 5 people is above 65 years of age currently. So Singapore's instruments for assessing population health and the system performance developed, as I said, over time. And each time the changes were in response to the factors the country was facing. So if you look at it, and I'm going to present it in a very historical sort of way, it really responded to what was happening at that point of time. So at independence, it was a country facing a developing country disease burden. This shifted over the years to a very chronic disease burden across 1980s and 1990s. Singapore faced 2 landmark infectious disease events. So even before COVID-19, there was SARS in 2003, which really was a big challenge to Singapore, who had never faced an epidemic like that before. So both of these events have been very influential on the policy as well. And of course, now, in addition to the chronic burden, as I said, is also demographic aging. So in Singapore, few functions that I'm going to talk about. First of all, let me move to the next slide, so this is the overview. I'm going to talk about systems and financing in general and how Singapore approaches it. So the financing architecture that is mentioned over here is also developed incrementally over all these decades. So initially there was a national health plan which set the direction. One key thing to note about Singapore rejected the idea outright of social insurance. So there are many countries across the world that have social insurance for health. Singapore rejected that because it viewed it as something that would drive oversupply and overuse. So Singapore's healthcare philosophy rests on personal responsibility. So the individual must take personal responsibility for their health, supported by the government, rather than the government providing healthcare and the individual consumes. So this is significant in the way that it financed and continues to finance healthcare. So what Singapore did is, I think it's one of its kind system. It has MediSave, which is a compulsory medical savings scheme provided within the Central Provident Fund. So every Singaporean citizen and PR don't have a choice in this matter. They contribute to CPF, and a portion of that goes compulsory into their medical savings account. Hospitals as well, which started off as public entities, were restructured and they became corporatized. So even though the state actually still owns them, the corporatizing of these hospitals made them compete on service delivery and for patients. So it introduced an element of efficiency and quality that the public sector wanted to include in there. In addition to MediSave, there is also MediShield, which is catastrophic insurance because MediSave was not enough. There's MediFund, which is for those for that section of the population who cannot even pay, even despite the subsidies through the other ways, through MediShield, etc. So as I talked about, there was this affordable healthcare white paper, which set the structure of individual responsibility. And around that, all the instruments, all the systems of Singapore measurement as well as financing and funding have been organized. So in practice, what happens is there is means-tested subsidies. Means-tested meaning not just income, but whatever means you have. Based on the means testing, you're given a percentage of subsidy. And this varies across. This can be as high as 80% of subsidy. Only then your MediSave will come into account, then MediShield, MediFund, etc., with additional support for certain age groups and certain conditions as well. So this is why the out-of-pocket spending has fallen so much because of these subsidies and the way the government procures and supplies healthcare. In terms of performance of the system, there is no single way that the country looks at it, looks at benchmarks or doesn't look at outcomes. Performance is generally against whatever is the current strategic framework. There was a master plan in 2012, which was very much about health care delivery. There was Healthcare 2020, which then started concentrating on access, quality, and affordability. And now finally, the framework has shifted to Healthier SG 2023, where this has seen the shift very clearly from hospital to community and from volume to value. So the journey through these documents is very clear of how Singapore has approached or gone through the burden that other countries are also facing. So Singapore does publish statistics on weekly bed occupancy, waiting time for all these hospitals, operational performance. They are always aggregate. They tend to be aggregate, and hence sometimes the disparities that may occur of population groups certain kinds are hidden because of this aggregation. So in terms of delivery, again, there used to be, it was very provider-based, as I said in the beginning, and it has moved from provider-based to population-based accountability. So the delivery units were public hospitals and polyclinics, which were grouped into first 2 clusters and then into 6 different clusters. But recently, as of 2017, they were reorganized into integrated clusters, which provide the full continuum of care from primary all the way to acute to tertiary care. And each of these is anchored by one medical college. So they also, around that medical college is the delivery system. But the more important thing of this reorganization into 3 clusters is that they were designated as regional health managers. So for the first time, the government put the onus or put the responsibility and accountability for these health clusters to manage the resident populations to keep them healthy. So initially the clusters only provided services. Now they got accountability for keeping their entire residential population healthy. Each of these clusters manages about 1.5 million people and now tracks indicators that it didn't track before. So not just ill care, but it tracks healthy indicators as well. And this again was reflected in the funding. So the funding changed and it went to capitation based on enrolled patients or enrolled citizens into program or enrolled citizens to a GP, which the new framework is now emphasizing. Health workforce, of course, is a challenge in Singapore. As I said, there are 3 medical schools and where training is there, but historically, Singapore has always relied on foreign trained doctors and nurses to fill the gaps. So this is a structural, because of the small size and because of the limited population, and shifting to this population-based model and expanding primary care and community care, again, changes the workforce. In the mid 80s, 90s, there was a huge push for specialists. So the government funded specialists, encouraged all the graduating doctors to specialize, super specialize, etc. And then they had to change that to now emphasize a generalist approach, to emphasize more primary care and GPs as well. And these signals have come through in improving the primary care physician base, retraining specialists towards generalist roles by calling it reskilling, especially ones who don't want to have that kind of lifestyle, or making it a lifestyle choice to move back towards a generalist role than to stay in the specialist role. So this is how Singapore is trying to shift how its workforce, even the trained workforce, performs as well. In terms of what instruments and how it measures its population health, so again, at the beginning, because of the developing country burden, there was the very standard things of vital registration, communicable disease notifications, infant mortality, maternal mortality. The Singapore Cancer Registry is a really interesting registry. It's established in 1968. It's one of the oldest in this region and the oldest continuous registry for cancer that has continued over all these years. As I said, as the burden shifted to more chronic diseases, the instruments changed. So the National Health Survey used to only be once in 6 years, but that was no longer capturing the very rapidly changing profile, risk profile, or even cardiometabolic profile of the population. So it has now been replaced with a National Population Health Survey. It's run jointly by the Ministry of Health and the National Health Promotion Board, and it runs annually. So the measurements happen once in 2 years, but interviews and behavioral surveys happen every year. So this faster track helps the country get very current data on cardiometabolic risk. So again, similar to others, burden of disease estimates, which Singapore has been producing since 2004. So it gives you the comparative version of, across against other countries as well. And the National Registry of Diseases Office has been covering cancer, as I said, since 1968, stroke, acute myocardial infarction, end-stage kidney disease have all been included in the long running registries. And then coming to surveillance. The two landmark events that happened in terms of SARS and COVID-19 set the foundation for how Singapore does surveillance. The legal instrument is the Infectious Disease Act from 1976. But SARS and COVID really changed policies, changed things since then. So isolation capacity for patients or infectious disease patients was expanded. Infectious disease workforce was only 11 physicians in 2003 when SARS hit, and it is over 75 now. So that was a change. Pandemic simulation exercises are done across the island, across all the public hospitals every 3 to 4 years. There was a communicable disease center which has operated, from the time it was colonized, and it has been replaced by National Center for Infectious Diseases, which again integrates clinical, laboratory, epidemiological functions as well. So for all these functions, Singapore uses data from some broad categories, which administrative and operational data, which it gets from these three main clusters or regional health managers and the Ministry of Health, population data from the annual survey, registry data, and international comparative data on the burden and disease. The interesting thing is that there is a gap actually in terms of a national electronic health record. So the data infrastructure was incomplete because private provider participation was only voluntary. And even among the clusters, everybody used a different system. So even for 6 million people, they didn't have a unified national health record. But that is changing out. As of very recently, a health information bill was passed in 2024, which is going to make it mandatory for every licensed provider to provide certain basic data. And again, that will enhance how Singapore measures. So just to conclude some few observations, in terms of all these things that I've talked about. Singapore's system definitely took decades to build, but there was a very clear sort of thought process and sequencing which reflects what the country or what the health system was facing at that point of time. So what the country measures very well is all these statistics, all these disease burdens, etc. But as I said, the distribution is not measured well. So catastrophic spending on healthcare, for example, is not published. While we know that out-of-pocket expenditure might be so much and universal health coverage is so much, but actually catastrophic health expenditure for households is not known, except, of course, by the Ministry of Health. So there are these equity challenges that Singapore does face. In terms of reforms, as I said, the shift from the 6 to the 3 clusters which manage population health was really pivotal. So providers being paid now based on enrolled population and given capitation funding makes them really responsible for health and not just for providing a service. So in this case, because they have to measure it, then they get funded for it. So because they get funded for it, it is measured very closely. And even the population health instruments I talked about, they followed this pattern over the decades. The annual survey that was there, the 6-year survey that was there, that measured a lot of infectious disease sort of burdens, has moved very much to annual to measure more cardiometabolic burden, which tends to have a risk profile that increases significantly quickly. So I think the caveat only that I would add, as I said at the very beginning about Singapore, Singapore went very quickly from a GDP per capita of about $500 in 1965 to roughly 90,000 today. So it reached high income status in a single generation. So, and that makes it unique because it has the fiscal capacity to heavily subsidize care for its population. It has the administrative capacity to mandate, whether it's reporting, whether it is burdens, it can mandate and enforce. Plus, the public sector comes with a very strong element of trust and a very low level of corruption. So it's a very trusted system and everybody contributes to this system as well. So again, single tier of government, there's no question of local versus others. It's just one single tier of government. So these are some of the caveats that make Singapore such an interesting story, but it's well designed for what is meant to capture. Its trajectory does have some lessons, I think, that can be applied across the region as well. I will end there. Thank you.
Thanks, Rohini. I think, again, I think Singapore illustrates a different dimension of this core governing function. I mean, the same thing can be applied to a district in India with 2 million population and a medical college for every district. And the cluster concept can be easily adopted. I mean, what I think illustrates from your presentation is that concept of learning system. I think the Singapore system has been adopting to the learnings that are coming out from the monitoring and assessment and the surveillance and some of the public health crises that happen to move from one stage to other stage. I think, while Arun illustrated the advantage of the local governance system and the subjective assessment systems, Singapore illustrates that adaptive and responsive governance system to the changing healthcare needs of the people and also the what the country can afford. Thanks, Rohini. I think then due to time challenges, we will come back with some questions. I will move to the last panelist, Supriya, to speak more on what the information technology and the information systems can actually strengthen some of the weak points that exist across health systems. Supriya, over to you.
Thank you, Dr. Reddy. Let me just present my screen. Okay, is my screen visible?
Yes.
Yeah. Okay. Yeah. Good afternoon, everyone. My subject is going to be summarizing a lot of information that we heard from the rest of the speakers, but it's mostly going to be around how digital technology can make three things smarter: the way we assess, monitor, and watch over the health of population. So let me begin by saying that I think we've never measured health more closely than we do today. Yet, guess the decisions that follow are often not as sharp compared to the amount of data that we capture. So this is again not because of shortage of data. It is health intelligence, the ability that to turn data into something that's worth acting upon. So consider what digital technology actually does here. It changes what a system can see, but it does not is how the system decides or what we can do with that, what we decide with that change. And that gap between seeing and deciding is where governance lives. So let's understand what the actual problem is. So I guess my argument is that governance is an information problem. So I guess for 2 decades, the binding constraint has been that we have too little data, so more of it needs to be collected. But that constraint thankfully has shifted. Most health systems today are extremely rich in data, but quite poor in terms of health intelligence. More information is gathered than ever before, but the decision still arrives late or sometimes never at all. So the problem has actually moved downstream from gathering data to converting it into something that can be acted upon in time. So health intelligence is in this sense, the insight that reaches the right hands early enough for change to be made before the moment passes. And governance depends on that, not on the data alone. So it's also important to understand that the question asked of governance has also changed. So historically, what we were tracking or what we were measuring is mostly how many facilities were actually built, how many workers were trained, were services actually delivered, was the budget spent. So this basically measured effort and not really the result. So the question now is that whether programs improved health outcomes and whether it improved those outcomes equitably and sustainably, and whether this equity widened, and whether the quality, resilience, and financial protection held. So if this sets the test for the new era of monitoring systems, whether it's going to be digital or otherwise, these are the questions we have to answer. A system that only counts activity faster has only changed the way governance works in terms of speed. So it's only changed the speed of governance and not the kind of governance. So monitoring systems earns its place only when it moves from a system from the first set of questions to the second set. So from the left side to the right side. So let's understand why this actually matters. So if outcomes are the new set of tests, then it's worth being clear about what these outcomes actually mean. So the functions that we talk about themselves were never the goal. That is, assessment, monitoring and evaluation, surveillance. These were just the means or the tools that we used. So what matters is what they finally deliver, which is on the right-hand side that we see, which is better population health, greater equity, financial protection, higher quality, public trust, and a system that's resilient enough to hold pressure. So these, I guess we could call as 6 of the parameters to measure real good governance. And what stands between these two functions are the outcomes. These functions and the outcomes are the way the data is used. So if this data is used well, it can protect people, it creates public value, and it can share benefits fairly. So this is what turns measurement into better lives. So let's look at what digital technology can actually change in terms of each of these functions. So 3 functions sit at the center of this. So assessment, monitoring, evaluation, and surveillance. And what digital technology can actually do in terms of strengthening it or providing it with a new strength is that assessment used to be a survey that was run every few years on scattered set of data. But with digital technology, it can give a continuous picture of the whole population. Monitoring and evaluation used to be a report read months later, but now with digital technology, it can show performance, quality, equity close to real time. Surveillance also used to catch problems much later and also in pieces. Now it can give early warning signs. But each of these strengths come with a condition. The condition is that how data is governed. A continuous picture is only as good as the data behind it. So the data must be highly representative, high quality, and has to be consent aware. So real-time monitoring needs shared indicators, good quality, and systems that can connect. Early warning needs to be careful, needs to use careful use of safeguards and public trust. So I think it's safe to say that digital technology creates that capability, and health data governance. It's not specifically health data governance is what makes that capability trustworthy and usable. So let's look at this infrastructure of how we can ensure this data governance and the data that we use can bring about the required intelligence that is missing in this entire picture. So at the base of it is the digital public infrastructure, which is comprised of the identities, the registries, the health information exchange, consent architectures, etc. This is the layer that's extremely foundational and is important, which enables data to move from one place to another. So on top of that sits the governance of the data itself, and the layer that keeps it complete, accurate, fairly representative, and used for the right purposes. Now, this is the layer that makes data extremely trustworthy. Above this comes the health intelligence, where trusted data now turns into an insight a system can actually read and understand. Above this sit all the decisions that use the insight to prioritize where to act and how to respond. And at the very top are the outcomes, which we've been talking about, and the things that we actually care about, which is better health, more equity, stronger protection, etc. So each layer actually rests on the one above that. The middle layer, the governance of data, is the one that most reforms actually skip. And that is the one that decides whether everything above it can be trusted. So here is a close-up of how we could ensure that health data governance is in place. Health data governance is what turns the sensitive, personal, population-wide data into health intelligence that we can actually trust. It does 3 basic jobs. First, it protects people, keeping their data safe and guarding them from misuse, stigma, and discrimination. Second, it creates value by allowing data to be shared responsibly, connected across systems, and used for research and innovation that better data makes possible. Third, it keeps things fair, making sure every group is properly represented, because the people captured in the data are the people served by the decisions that follow. If that particular data is missing a certain section of population, the decisions also for that section is missed. So that brings me to the question, is more visibility a measure of great governance? I don't think so, because we all agree that integration of systems does give us a great sight, gives us the sight of what data is lying underneath. But health data governance gives us that legitimacy and the institutions that turn that into action. So it's important to understand that many systems first get started with integration. And that's when you see that records are linked, the dashboards are live, exchanges work, and together they give an extremely clear picture of what's going on. But the clear picture is where it all stops. And it's just the starting of things. Trust in the data, someone that's accountable, and an institution that owns the response. A view still needs to become a judgment. A dashboard is just going to be a collation of information unless it helps in making that decision. And technology gives us that picture. So institutions are what will help act on this data. And that is where good governance can actually happen. There is scope for it. We can see that play out in practice in this example that I have of a few countries. Now, I'd like you to look at this table as not merely like a league table, but mostly in terms of capabilities. Now, these countries have been chosen to show how they use all of these or some of it and have moved in their journey of using data towards providing the best outcomes. So United Kingdom shows good use of data. It tracks population health, directs care to where the need is the greatest. The Brazil shows power, the limit of scale. It has built one of the largest health data systems in the world, yet it still finds it hard to turn all the data into timely decisions. Thailand, on the other hand, shows what discipline looks like. Its district teams are use ordinary, everyday data really well to push towards universal health coverage. And then comes India. So India shows something that is foundationally strong. The foundation is laid in terms of the digital public infrastructure. We have the identities, registries, consent, architecture, exchange, etc. The tracks are in place, but the health intelligence is something that is still being built upon on top of it. So I guess a common thread here is that, in every case, data becomes governance only where institutions actually use it. So that brings me to the final question. Coming from India, will ABDM really improve the governance function? So let's take a honest look at it. ABDM lays down both digital highways and the rules that govern what travel on there. Identity registries is great. This is what matters. Yes, it is there. But the highways are the only starting point. The real value depends on what we choose to build on top of it and what runs on top of it. 3 most important bridges carry that foundation into governance. The first is the data bridge, making data complete, good quality, connected, and able to follow a person over time. Second is the intelligence bridge, the analytics that turns that data into insight, spotting risks, linking surveillance, and tracking real outcomes. And third is the institutional bridge, clear decision insights, accountability, and the right incentives, and the right real use on the ground for the states to take action. So if we were to judge this entire these functions like the assessment, monitoring, evaluation, how does ABDM help in moving the needle? So assessment, I guess, considering what we have today, could improve significantly as the records and registries reach a whole population. So the enumeration has to reach the entire population. Monitoring and evaluation could improve moderately once the adoption, data quality, and outcome measures mature. Surveillance could improve significantly, but only if it is deliberately wired into the public health workflows, without which it's absolutely impossible and it's going to stay siloed. And population health management is just emerging. As long-term records and risk tools develop, there's a long way to go. And then comes governance. This stays conditional because it all depends on the analytics and what we build on top of it. The institutional capacity, incentives, and how responsive actually the policy is. So the pattern is very clear. I guess the answer, an honest answer to this is a qualified yes. This is not a praise or a criticism against these initiatives, but it's just an honest understanding of where things lie. I'd like to conclude by saying that assessment, monitoring, surveillance have all become extremely sharp in the recent years with the collection of a lot of data. Seeing is the part of technology that makes it possible. The hardest step is turning what we see into what we decide. So that step is governance. Now, infrastructure is required for it to move the data. Health data governance makes it extremely trustworthy. Trusted data then becomes health intelligence, which is what we need. And institutions turn that intelligence into fairer outcomes. So digital technology makes these functions smarter at seeing. Turning that into better decisions is the work of governance. So I would say that digital transformation is mostly a governance capability that is supported by technology, and it's just not a fully technology initiative. So thank you very much.
Yeah, thanks, Supriya. I think we had a interesting insights into different aspects of this core governance function at a global level, national level, state level, and a city-state level like Singapore. And I think Supriya has brought out the real challenge of leveraging the digital technology is not the driving efficiency, but how this technology should drive effectiveness of this governance function. I think that is where the critical gap is, how this information is used, transformed into intelligence to inform correct decisions. And ultimately, Maulik started with the core function of assessment and other things is to ultimately improve the health status of people and meet health needs of the people in a responsive way. What I think what came out through this series of discussions, at least from my point, I could summarize that the most effective way of this governing function is to take it to the local level, at a primary health center level. The same function, if the primary health center takes the responsibility to monitor its population under its responsibility, maybe 30,000 people or 50,000 people or whatever the number of people. Because if we can test this at a decentralized level, what Arun has clearly mentioned, where the people have the competencies to use the information, however fragmented it is, however subjective it is, the ability to use that information into effective action. I think that was coming out very clearly. There are, I think, in the question answer session, I mean, there are no questions posted in the question and answer board, but if anybody wants to unmute their mics and then ask questions, they can do that. Or else the speakers can ask other speakers any questions that you have to other speakers as a more interactive discussion. I mean, you can raise your hands. Otherwise, I will start asking some questions. Maybe I will go to Maulik to ask the question. I mean, Maulik, I think the framework that you articulated is the real framework in terms of bringing in the whole of government, whole of systems approach to the health system. So that means in the Indian context, where does the actual convergence of all this intelligence happens? Is it at the PMO level or Niti Aayog level or ministry level? Because ideally, if it is a whole systems and whole of governments approach, it has to escalate to the top at the PM office level at the center and CM office level at the state. What is your perspective on that?
Thanks, Dr. Reddy. And that's a very interesting question. I think so. When you got multiple departments or ministries coming together, PMO plays a very important role. And along with PMO, I gave an example as Ministry of Finance playing a very important role. Because, I'll take again health financing as an example. If let's say there is fiscal deficit at a state level, and they still want to, and there is a genuine need. If I go with Rohin's argument, equity, if there is a genuine need of building an infrastructure, states are not in a position to allocate resources. That's where the federal government comes into picture of allocating resources from the general tax kitty that GST and corporate tax kitty, they can allocate resources. And henceforth, the role of Ministry of Finance becomes very, very important. But then also it becomes a kind of, I would say, it's not as simple as I'm saying also. Because let's say if I want to build in, if anyone gives money, right? If someone is paying me money, they want certain outcomes. So if there is a continuous enhancement of resource allocation from federal government, it also brings in accountability of that particular state to federal government. And the data sets then resides with federal government and not with the state government. So I think that it's a complex thing. And I'm just taking just health as an example, but then we start talking about, and this is a classical scenario. If I want to decrease access to medicine, we know that affordability is an indicator. To decrease the prices of medicine, taxation has a role in decreasing prices of medicine. If I decrease the price of medicine, it affects the corporate revenue that I get from corporate tax because my overall profit margin has gone down. So, and that's when again the Ministry of Finance can play a role. So, and it also shows the complexity of different objectives that we have. Ministry of Corporate Affairs would like to contribute maximum to GDP of the country. So, profit maximization makes sense. But Ministry of Health wants to make affordable medicines available to everyone. So decreasing kind of cost of medication makes sense to them. And henceforth, someone needs to play a balancing act where PMO and Ministry of Finance plays a very important role. Thank you.
Thanks, Maulik. I think I understand it's very complex, but again, I think institutional mechanisms can be built despite the complexity at a national level monitoring and how that information is actually shared with the state levels for them to make appropriate decisions at a state level, because some of the information is only flowing into the federal system, not at the state level.
Interesting thing, if I may add to what I said earlier, I think so a couple of years back, there was an effort to create a national agency which has got all this data flowing in. But I think so that agency took a different kind of structure right now and it is named the same stuff. But yes, as you rightly said, that COVID again has given as example the way surveillance and vaccine data needs to come together, and a need of having a convergence of data flow with a real-time data flowing in. And you rightly pointed out there. Thank you.
Thanks, Maulik. I think I'm reminded of the time, 3:30 though, I mean, we have flexibility to stretch time because we wanted, because everybody will have some commitments beyond the time. But as I mentioned in the beginning, I think since this is going to be a series of sessions on the same topic of governance, I mean, some of the speakers, I think we will request them to come back next month as well to answer some of the questions the audience might be reflecting meanwhile. Because in the next session, I think we will try to take the perspectives from the actual practitioners, whether it is at a ministerial level or, I mean, we can call ex-ministers, if not the current ministers, and ex-IS officers or ex-administrators from different countries as well. I mean, I think we will have practitioners, because this session was more from the researchers and subject matter experts. We will try to understand their perspectives from the practitioners as to how actually they use the information. Because as Arun said, a lot of decisions, I mean, as a good clinician also, I depend a lot on the subjective assessment, in addition to objective confirmation of my subjective assessment. But sometimes in emergency situations, I have to take decisions on subjective assessment. This is a interesting discussion. Suti, if you permit me, then I, with apologies for any other speakers for questions, I stop here, but I think we will continue this dialogue in the coming sessions every month. So over to you, Stuti. I think you can make the closing remarks.
Yeah, thanks, Dr. Reddy. There's just one more question. I think we can answer that over email. So thank you everyone for joining us today. We really hope that the session offered meaningful insights for you. A sincere thank to all our speakers and all the audiences who have joined us. As Dr. Reddy said, this is a part of our monthly series, so do watch out. We will be sharing details for the next session, which will happen next month. So we look forward to your continued participation, and thank you once again and have a good evening.